Hello, Supervisor Ellenberg. Can we do a mic check, please?
Yes, we can. Hey, Dave, how are you?
I'm well, thank you. How are you?
Just dandy. Thank you.
Okay.
All right.
Thank you
see in
very
a bit.
much. Thanks. Hi, Key. Let's go ahead and do a mic check with you, please. Key, whenever you're ready, let's do a mic check, please. Hello, Supervisor. Can we do a mic check, please?
Certainly. And is this Dave?
Yes, it is.
Hi, Dave. This is County Supervisor Joe Simidian. Do you have visual? Let's start there.
We have visual on you, sir, and we can hear you loud and clear. Thank you.
Thank you. I will flick off both the video and the audio for just the next 5-6 minutes. I will be back at about 12:59 and a half. Okay?
Understood. Thank you.
Thank you.
Hi, Renee. Can we do a mic check, please?
Hi, this is Renee.
We can hear you. Thank you.
I'll be on mute.
Got it. Thanks.
The mic check from Key.
Hi, Key. We can hear you. Thanks very much. Miguel, hi. Whenever you're ready, let's do a mic check, please.
Hello, mic check from Miguel.
We've got you. Thanks, Miguel. Hi, Sherry. Can we do a mic check, please?
Sure. Good afternoon. This is Sherry Terrell.
Good afternoon. We can hear you. Thank you.
Thank you.
Hi, Doug. Can we do a mic check, please?
Sure. Good afternoon. Can you hear me?
Yes, I can. Thank you very much.
Very good. Thank you so much.
Hi, Paul. Can we do a mic check, please?
Hi, this is Paul Lorenz. Good afternoon.
We can hear you. Thanks very much.
You're welcome.
Hi, Paul. This is Doug.
Hi, Doug.
Hey, Dave, this is Key. Dr. Jeff Smith is in here with us.
Understood, Key. Thank you. Hello, Dr. Nguyen. When you're ready, let's do a mic check, please.
All right, ladies and gentlemen, it is time to begin our 1 p.m. special meeting of the Santa Clara County Health and Hospitals Committee. And let me first ask if the clerk is reading us loud and clear.
Yes, sir.
Thank you very much. The first item of business, of course, is simply to call the meeting to order, but we also want, just for the record, to establish the presence of the quorum. So while it's a relatively small committee, could we ask the clerk to please call the roll just to establish the presence of a quorum, please?
Good afternoon, Vice Chairperson Ellenberg
I am here.
and Chairperson Simidian.
And I am here as well. The presence of a quorum has been established. Thank you all very much. Supervisor Ellenberg, I thought it might be helpful, even though our agenda is, it is both long and wide ranging, and yet has just 3 or 4 items on it to share with members of the public and the staff the process here. We have primarily one item, which is the item number 2 on our agenda, the next item, which is the special hearing relating to the current status and future development of coronavirus testing, including both the polymerase chain reaction and the serological testing in Santa Clara County. We have two-person panels. It's my intention today to hear first from the panel regarding testing, including a discussion of the epidemiological and economic necessities and benefits of widespread testing. I'll come back to that in a moment. Then there is a second two-person panel, which is the panel discussion relating to operational aspects of coronavirus testing, including strategies for increasing testing capacity, availability, and access for residents of our county. And that is expected to include a discussion regarding the practical or logistical challenges that may exist and the increased testing path going forward, if you will. My plan, Supervisor Ellenberg, is to do the 2 panels under item number 2, to then take comment from members of the public after we've heard those 2 panels. And my reason for doing that is to manage some scheduling challenges that we have with respect to folks who are participating in the panels. We thank them again, but I want to make sure we have time to hear from both panels, have your questions and my questions and comments, if any, addressed to the greatest degree possible. Then, and only then, will we go to members of the general public who want to comment on item number 2. And time permitting, depending on the number of folks who want to comment, my inclination is to do the standard 2 minutes for folks who want to comment on that item. That would then take us to item number 3, which is our general public comment. And of course, as you know, we set aside time at each committee meeting for public comment on any topic not agendized that is properly within the jurisdiction of our committee. So I would take the public comment at that time. And I think I'll hold off in making a judgment about how much time we can provide for public comment on general matters at the end of the meeting until we see just how many folks we have who are with us and would like to comment. Supervisor Ellenberg, I know that as I've talked with you about the panelist schedule and our own schedules, you and I are shooting to make sure that we wrap this up no later than 3:30. Just wanted to confirm with you with a nod of the head, thank you for that, that 3:30 is our target time, if not earlier, although given the range of the subject matter, I think that's unlikely. So Supervisor Ellenberg, unless you have any comments or questions about just how we proceed, I'll let the clerk and the members of the public who are listening know that's the plan. Any additional thoughts, or does that work for you?
It's an ambitious agenda. It works for me. Let's see how it goes.
Thanks very much. So let me begin by introducing and thanking our first two-person panel. Dr. Bonnie Maldonado, who is with us, and I see her in on our screen, is the chief of the Division of Infectious Disease at Stanford Medicine. She's also the medical director of infection prevention and control at Lucile Packard Children's Hospital, has been since 2006. She's the senior associate dean and the professor of pediatrics, infectious disease, and health research and policy at Stanford University School of Medicine. And she received her MD from Stanford University School of Medicine back in 1981, followed by a residency and a fellowship at Johns Hopkins Hospital. Then we also have with us, I believe, and I'm looking to the screen, is Dr. Charlie Kim with us. There you are. Thank you, Dr. Kim. And Dr. Kim is the head of the molecular systems at Verily Life Sciences, has been since 2015. Also a professor of medicine at UCSF in the Division of Experimental Medicine, where he has been since 2011. At UCSF, he studies the genomic and bioinformatic analysis of immune activation and tolerance, and we may learn what all that means in a few minutes, perhaps, during chronic infections and diseases, including HIV, malaria, and diabetes. And Dr. Kim received his doctorate in microbiology and immunology from Stanford in 2004, was a postdoctoral fellow at UCSF in the Department of Biochemistry and Biophysics from 2005 and 2011. So let me, while we will have more specific questions, let me start with Dr. Maldonado, then go to Dr. Kim, and ask each of you to share what you think is relevant and important about the relevance and importance of testing, and of course, sharing the observations on two different kinds of testing, which play a very different role in this conversation. So Dr. Maldonado, let me go to you first for opening remarks. Thank you.
Thank you very much, and thank you for inviting me to speak to this group. I don't have any prepared statements, but I'm an infectious disease epidemiologist and really approach epidemiology of infectious diseases from a research standpoint, a clinical standpoint, as well as a population health standpoint and a public health approach as well. And so testing for presence of infection of SARS-CoV-2 or the COVID disease is a very fundamental and critical component of our ability to identify the natural history of this disease, to understand the different components of the infection in different populations. So for example, understanding the manifestations of the disease in different places by knowing who is really infected versus those who might have a clinical syndrome that appears to be COVID, but may be something different. It also helps us to understand therapeutic interventions because we can measure, we can identify people who are infected, enroll them in clinical studies, and have a way to identify important populations to treat. It also plays a major role in understanding prevention and public health interventions. From the prevention side, obviously, we would like to know what the scope of the disease is, and I won't go into the details now, but from an epidemiologic standpoint, we do really need to understand what the prevalence is, or the overall cross-sectional number of people who might be infected. And if you do that in a clinical approach, you're going to either overestimate or underestimate disease. Overestimate because you may actually call some people infected when in fact they have other syndromes that may look similar, and underestimate because there may be a number of people who have either a prodrome, that is they are or pre-symptomatic, they're infected but they're not quite yet symptomatic, or they may be completely asymptomatic, that is they may never develop disease. So you have a risk on either side of over or underestimating this disease. So that's from a prevention standpoint, it's important to know who those people are so that we can then develop approaches to provide interventions, either clinical or public health. From the public health standpoint, once all of those things have been addressed, and those are being done all at the same time, I presume, you need to test on an ongoing basis as well as a cross-sectional basis to understand which populations are more likely to be infected, so that you can develop effective interventions. You also want to be able to check in on a regular basis around testing so that you can see whether interventions have worked. That is the rate of infection going up? Is it going down? Is it staying the same? And if it is going up, you want to be able to identify whether there are specific areas in the population where infection rates might be going up, and then go back as a public health agency to investigate why that might be happening. And so that's just a very brief introduction around why testing is so important. For every disease that we have, when we don't have a specific test, it is a syndrome and not a disease, and it's much harder to understand the mechanisms of the disease, how to develop treatments, how to develop preventive therapies, and how to track it in the population. Thank you.
Thank you. I'm going to go to Dr. Kim for brief opening remarks. And Dr. Maldonado, thank you. You focused on the sort of the core question here, the starting point, which is, why does testing matter if it does? And you've indicated rather clearly that it does, and helped provide some insight into why it matters. Let me tee up the sort of the starting point that way for Dr. Kim as well, which is, as we have this conversation today about efforts to expand testing in Santa Clara County, is it important? Why is it important? And what would we do with it once we had that information? So if that helps frame the conversation a little bit, and I hope it does, is it important? Why is it important? And what would we do with the information once we had it? Dr. Kim, to you.
Yeah, and let me start by sharing my thanks to the supervisors for providing this opportunity to share some of my personal thinking, my personal experiences, and also more broadly how the scientific community is thinking about these things. My experience with COVID has really been through the company I work for, Verily, being involved on the front lines of getting testing out into the communities. And even though I'm a PhD, more of a laboratory scientist, I did have the opportunity back in March to actually set up the Santa Clara County Fairgrounds testing location, where we've set up the drive-through testing, and really see on the front lines what was being done, what was needed, and what we needed to do more of. And I'll just echo a lot of Dr. Maldonado's sentiments around why testing is needed. I'll maybe complement some of the scientific background with just my own personal experience too. So I'm a San Mateo County resident, formerly in Santa Clara County resident when I was doing my training at Stanford. But my folks live down the street. They're a mile away, and they're in a high-risk group. My kids, were going to school until the end of March, and I didn't know how much COVID there was in their school and whether or not they could see their grandparents or not. So we just had to take precautions and isolate. It's been a few months now since my folks have seen their grandkids. And so these are the sorts of real world questions that I think a lot of our community residents are grappling with. Like, when can the grandkids see the grandfolks? Can the grandparents go to the store? What kind of precautions need to be taken? How much immunity is there in the community, or at least antibody? We don't even know about immunity yet. And how much virus is out there in the community? These are all really critical pieces of data that we need, the citizens need, that the counties need, public health officials need to inform the policy decisions about how we can get back to our normal lives at even as a modest semblance of what we consider to be our normal lives, but make sure we're also protecting our most vulnerable populations to the extent that's reasonable. And we have to balance all these things really carefully to be able to do that and work in partnership with one another.
Thank you, Dr. Kim. And Dr. Kim, Dr. Maldonado, and others, during the course of the conversation today, I'm going to try and put some words in your mouth as we go through the conversation, because I'll want to bottom line Part of the challenge we have is that you know so much. I want to make sure that we sift out the nuggets that are most important for decision making at the county. If, as I do that, I either say something that's inaccurate or that is not an accurate representation of what we've heard from you, please lean in, correct, clarify, tell me I just flat out got it wrong if that's the case. But as I say, I want to walk away today with a half dozen bullets that are the understanding. And on this issue of importance, what I heard you both saying is we can't have a public health strategy that addresses COVID in our county without adequate testing. That was the first thing I heard. The second thing I heard was that if we're going to talk about lifting restrictions to address some of the real world questions that people have, we need to understand what's out there and how it's working in our community. The third thing I heard was that for certain workforces in particular, and I'm thinking of congregate care, for example, long-term care facilities, but it could also be our own hospitals or clinics, that it's going to be particularly important that we test people so we know who is or isn't appropriate to enter a particular space. And the last thing I heard was that this is really going to be important for all of our businesses, frankly, as they try to get back to work. They're going to need to know who does or doesn't have the virus. Let me start with Dr. Maldonado and then go to Dr. Kim. Did I get that more or less right?
Yes, that was accurate. Thank you. Very well put.
Thank you. Dr. Kim?
Yeah, absolutely agree. It starts with the data to make the decisions, right? We need the data.
And Supervisor Ellenberg, I know you've got a number of questions today, but as we sort of work our way through some of these threshold questions, if you want to lean in and follow up, just if you give me a wave, I will call on you. Do you have any follow-up on those initial presentations or questions or something?
Not yet, but I won't hesitate to do so.
Thank you. And just keep waving if I don't happen to see you with all the squares on my screen here. Let me just ask, and this will ultimately be a question we have for our second panel, which is more operationally oriented. Let me start with Dr. Kim and then go to Dr. Maldonado on this next question. What are we to make of the efficacy of the multiplicity of tests and testing sources / providers? Part of the challenge that we've had over the last few months is, in my observation at least, and correct me if you have a different take from your professional perspectives, no one has really been responsible for rolling out a testing program. Not the federal government, not the state government, not the county government, not our city governments, some of which are large, some of which are small. But what are the implications of that for the work we're trying to do, given the fact that the sites that we have that are open already in Santa Clara County are some are commercial, some are academic. We have our own public health operation. Thoughts, Dr. Kim, as someone who's been involved in putting one of these in place?
Yeah, absolutely. And I'll just agree with you as a starting point that it has been remarkable that, especially in contrast to some regions of the world, South Korea comes to mind as a place where the testing program was very organized and structured. That's not to say we're doing anything wrong or anything like that. They had a very well-developed infrastructure because they had seen SARS, MERS every few years. This is something that's relatively new to us, and so we're learning along the way. We haven't had the learnings from these previous epidemics to really harden our infrastructure and expertise in this regime. So we are learning along the way. I think there are benefits to having a central and mobilized infrastructure, certainly in terms of just being less confusing and having a less redundant effort. That could have been valuable. And maybe that's something that we'll see our counties and other, certainly the state of California is moving more and more toward that. But at the same time, we've been pretty remarkable at making things work overall. Some of the challenges with supply chain still remain outstanding. We still there's an international shortage of some of the supplies that are actually needed to do testing on larger scale. A lot of people are working on that. But overall, what I would say is we're making it work, and it's not necessarily the availability of or throughput of the testing that is that limiting right now. It's more around supply chain issues that are going to be a challenge for the future. The other thing to your first point about just the large availability of different kinds of tests that are becoming commercially available, that is also a big challenge. And there's a lot of academic literature that's starting to come out to really sort of separate the wheat from the chaff there. And that's an important step toward making sure we're generating the best data, the highest quality data that we can use to be the basis of the ultimate clinical and policy decisions that need to be made. And so we're all getting there, but the early phase has definitely been a challenging scramble where we're seeing a lot of people stepping up to the challenges, but still some pieces to work through as well.
Dr. Kim, first of all, thank you so much for the presentation and information. I'm thinking about you mentioned different types of tests that are available from different outlets. There's also the new antigen test that was recently approved by the FDA, and I'm curious to know what you think about its ultimate value, especially given my understanding is that given that a PCR test would still be needed to confirm a negative test. It makes me think of the rapid straps test that my kids had when they were younger. Is this something that's going to be really usable?
Yeah, absolutely, and it's a really important point to make sure when we talk about testing, there is the nucleic acid testing, the PCR testing, and that is really looking for the presence of the virus itself, which means is the virus in your body? Is it being shed in the mucus, for example? Which could mean that that individual is infectious. The second kind of test that we're seeing more of now is sometimes referred to as an antibody test or a serology test. And what that is it's sort of a historical record that your body has seen the virus and is mounting an immune response. So we have to be thoughtful about making sure, number one, that we're distinguishing what those kinds of tests are. Number two, using them in the right settings. And the way to think about the antibody tests that are becoming available is that if an individual has antibodies, there is a reasonable chance that that person is going to have some resistance to being reinfected. And so it's almost like the hope is that these tests can be used as an indicator that an individual has mounted an immune response and that might not need as aggressive nucleic acid testing, the PCR testing, to look for that virus continually. If an individual hasn't yet mounted an immune response, then they may need a little bit more intensive monitoring for becoming infected.
Are there particular settings or groups of population for whom one test or another might be more appropriate?
Absolutely. I think that, and it's not black or white, I would say, but there are certain situations, for example, in high risk settings. This might be first responders or in workers in senior care centers, for example, where the risk of infection is quite high. And this is where, and also not just becoming infected, but also transmitting infection. The consequences of transmission are very high. Those are cases where if a person hasn't developed antibodies, and even if they have, you might want to do very frequent PCR-based testing, because those are cases where you need to detect an infected individual very rapidly because the consequences are so serious. For other cases, you might be able to get away with, very infrequent PCR testing, depending on occupation being low risk for transmitting or becoming infected.
Supervisor, excuse me,
you.
piggybacking on your question for a moment, but Dr. Kim, before I go back to Dr. Maldonado in a moment, and I'll probably ask the same question of Dr. Maldonado. Do you have a view, for example, we know that 40% of the deaths we've experienced in Santa Clara County from COVID are in long-term care facilities, assisted living, skilled nursing facilities. So the issue of testing has understandably, the PCR testing has understandably come up in connection with those facilities in particular. Any view on how often someone should be tested, since implicit in your comments is the acknowledgement that all the test shows us is the status for a PCR test, all the test shows us is the status of the individual at the time of testing, yes?
That's absolutely correct, yes.
So then the question is, if we're going to send somebody in who is a caregiver in a long-term care facility, or someone who is serving meals to residents, if if by definition all we know from the PCR test is whether or not someone has the virus at that moment, how often does that suggest to you that somebody in that circumstance should be tested? If you have a thought.
I absolutely agree. I'll leave my answer at more than that's a high risk situation and definitely warrants more frequent testing. I wouldn't be able to provide you with a specific day, and I think that a specific daily cadence. I think that that's something that really should be something where we need some statistical modelers and public health guidance on those kinds of matters to really decide. There are other factors there. If there are limitations in test availability, you've all heard about some of the challenges with obtaining enough personal protective equipment. All of these factors have to be weighed into that decision as well. It's not just a purely medical or scientific decision. So, we'll continue to work really closely under the direction of state and county public health officials to really figure out the best solutions there.
Thank you. Dr. Maldonado, we've opened up a lot of topics of conversation. I started by asking about the challenges and or benefits of having a multiplicity of tests that are administered by a multiplicity of providers. That also then took us into a conversation about the distinction between PCR tests and antibody tests and the relative utility of both. And that, of course, has now resulted in a sort of a further conversation about what kind of testing should be used in what settings and with what frequency. Supervisor Ellenberg, I think that captures much of the conversation that you provoked, and I mean provoked in the best of ways, of course. So Dr. Maldonado, do you have thoughts on those topics that you could share with us now?
Absolutely. And I think it's important to remember, I also run a virology lab myself. I know how to work in the laboratory. I also am an epidemiologist and I see patients. So I think that we need to take the totality of this information, and I can give you some other thoughts. So first of all, I disagree. I think that our federal system has failed us. I trained at CDC myself, and I know what it was like in the days when we identified HIV for the first time, and we needed that test. And you can read books and see movies about the test and how that system was not stood up in time and what happened there. So I think that our federal system has not provided us with the structure. And I agree with one thing, that we are doing the best we can, but I don't think we should be doing what we're doing now. I think that Taiwan, Hong Kong, China to a certain extent, Singapore, South Korea have been through SARS and MERS. We've been through SARS and MERS, but we were able to avoid most of that. But I think we are somewhat short-sighted in our ability to respond. Many of us have been talking about pandemic diseases for a long time. I work in developing settings to prevent, working in a number of infectious disease outbreak settings. And I know that these are real and front-facing, and a lot of people in the US did not hear that. So I do think that we don't have to have a centralized testing facility or testing approach, but we need to have a centralized response. And that is the failure of our system. And you pointed it out yourself. Everyone is doing what they can and everybody's making it up as they go along. We need to have a centralized way to, I think the supply chain is critical. It became very apparent that was a major gap, and without a supply chain, you can't do a test. Doesn't matter how much expensive equipment you have in your laboratory and how smart you are and how high tech you have it. If you can't get a swab, you can't do the big end test. So I do think that our system needed to give us more guidance at the national level and to help work with our networks. There are many, I work, for example, with the CDC now. I run a national committee for the American Academy of Pediatrics. So we know how to work collaboratively. It's not that we haven't done it before. We just haven't done it now for this. So having said that, I think that it is fine for there to be public-private partnerships, industry-based testing of all sorts. That's great. We need as much testing as we can get. But what we don't have is transparency around the testing. How good is it? How accurate is it? What's the capacity of the test? What does the test tell you exactly? In lay terms that people on the street can figure out, not just what us scientists and clinicians can think about or read about over 2 or 3 hours of pouring through the literature. So I think we need to be much more transparent at a high level about what's available, how to judge what's available. I mean, people are getting emails about, you can send for a test or you can drive over to Walgreens and get a test. But if that test isn't accurate, you might as well not have a test. So I think that's a major problem with our system. And I can say that because at Stanford, we've developed a test very early. We were probably one of the first privately owned institutions to build our own test, precisely because we couldn't get access to the federal test. Now, there are a number of reasons for that. And I was at CDC. My last trip before we were sheltered was to CDC. And we have had very little communication from them, and not because they're not good at what they do. So we developed our own test. It's highly accurate. We know that the false positive and the false negative rates are extremely low. And we have rolled out in excess of 50,000 tests at Stanford of healthcare workers and patients. But we would love to be able to get that degree of accuracy to everybody who wants it. And that's the problem. So moving forward, that's my high level answer there. Around who needs to be tested, I think it depends on, and lack of access to testing means that we also lack the access to the scientific reasons for testing. So I'm doing a number of studies, other people are doing studies with the testing that we have to understand who's at risk, what does a test mean at what point in your disease. So if you get a test too early, you're going to miss an infection. If you get it too late, you might miss an infection with a PCR. But the antibody test can fill that in. So we know right now for a fact, at least at Stanford with our thousands of tests and also our antibody test, that there are people who will not have an antibody or evidence of immunity, whatever that means, in the first 2 weeks or so of infection. So the many people, if they get the antibody test too early, may be misdiagnosed as not having been exposed. And right now, that's all we can say about the antibody test. It just measures exposure. By 4 weeks, it appears that most people will have antibody, but we're starting to see that in people who are severely ill, those who have been in ventilators in the ICU, may actually not develop antibody, and we don't even know why that is. We're trying to figure that out. And there are other specific tests that we can do to measure at a very granular level what the immune system is actually doing that the antibody test can't tell us. So until we have better information, we are dealing with this as best we can. And that's important because if we don't know, if somebody, as Dr. Kim mentioned, if we don't know what antibody means, we can't tell somebody, we can't tell our healthcare workers or our patients, you are protected for a year, for 6 months, or you're never going to be protected. That antibody just means you were exposed. And more importantly, or as importantly, we can't tell you if an antibody test means that you can get infected but not sick, but then infect people around you. Those are things that we're actively studying right now. So I do think that all of that needs to be understood within the medical community as well as as well as our general population. And I think we'll get there. I think we're doing a great job. Meaning we as a country are doing a great job because we do have people like Dr. Kim and our hospital medical centers and others, industry people who are building up as fast as they can. But I do think that we were not as prepared as we could be because of the general overall coordination of our responses.
Thank you. I'm going to have a couple of follow-ups, and then I'm going to look to Supervisor Ellenberg as well for follow-ups. And Dr. Maldonado, you mentioned the testing at Stanford, even though this panel is sort of more about informing our understanding of the significance of testing, the importance of testing, and the subsequent conversation is going to be more about the mechanics or logistics of it all. I can't resist asking, so what's the impediment that keeps you from doubling the number of tests you could do, just to pick a random multiplier?
Sure. We think we can actually. In fact, Dr. Kong will tell you a little bit about that, I think, next hour. The limitations are, first of all, it took us a little bit of time to remember. We've only known about this virus, at least in the US, for about 4 months or so, plus or minus. But the ability to build, I mean, I can build a test like this in my lab. I've done it for other viruses. It's not, I wouldn't say at this point in our technical skills sets that it would take months and months to do that. It's pretty straightforward. But what you want to do is make sure the test is accurate. And for that, you need to find people who are infected and people who are not infected. So you can see how well the test works in both of those populations. And so I think at this point, what limits us right now is reagents. We've built up 3 different large platforms. And by platforms, I mean big machines that can each run hundreds to thousands of tests in one day. And we built 3 of them, or we bought 3 of them, because the first one we had already is how we built our first set of tests. But we were limited by the amount of supply that we could get to run the test. So we were actually asking people to donate their test kits, the enzymes and all of that we needed to let us do the testing. And then we were able to find vendors around the world to give us more. The second platform is we brought that in, and it took us a while to just build it up and make sure it worked properly. And then the third platform is a platform we also already had, but we needed the special little cartridges that we needed to enter, the company had to make it specific for this. So at capacity, and we could double our tests in a matter of weeks, I would think, if we had adequate supplies, not of the machines or the patients, but of the swabs and the enzymes and all the chemical solutions that we would need to be able to do that. The task force, and I thought we were alone here at Stanford in that regard, but I've been on weekly meetings with this governor's task force on technology and innovation, and every single other academic medical center in California that's on the panel with me has said the same thing. So we could do a better job if we had access to supply.
So supply chain issues are still a significant factor in limiting the number of tests that you can put out in the field. Is that a fair summary?
Yes, absolutely.
Thank you. You made a simple declarative statement, which was we need as much testing as we can get. So let me ask the question this way. If you had as much testing as we could get, let's say you could multiply the number of tests times 2, times 5, times 10. What is the most important thing you hope to learn from having that volume of, let's start with the PCR test and then go to the antibody tests? And I want to go back to Dr. Kim on that same question in a second, and then go to Supervisor Ellenberg so she can probe a little bit more as well. But if we had that volume of tests, that would be really important and helpful, because why? First PCR, then antibody.
Yeah. So the most important thing that it would tell us, I think, is the how extensive is the infection in our region, in our city, state, wherever, name your location. How prevalent is the infection? How much infection do we have right now? We need to know that so that we can understand exactly all the points that you mentioned. How do we control the spread going forward? And if we know who's infected, we know how to provide mitigation to keep those people from being infected, from infecting others, sorry. And I think right now, the problem is we know from, at least from what's happening in China, or what's happened in China in particular, because they had large numbers and they reported them, that we know that about a third or more of people can be asymptomatic. That is, they may be infected and have no symptoms, and they may transmit infection to others. And if we don't know about that population, we won't be able to effectively prevent further transmission of disease. So that's important. And your second question was about antibody testing?
Yes, and if let's say we could ramp up our antibody testing with, to your earlier point, and Dr. Kim made the same point, with a test that we knew was reliable, so starting there, given the uncertainty about what benefits the antibody does or does not confer, what would the benefit be of dramatically greater numbers of antibody tests out in the field? Again, assuming that the test itself is an accurate one.
Right, assuming we knew everything about what the antibody means, which we're actually trying to figure out now. So for example, does it mean you're protected? Do we know what titer you need to be protected? Does it protect you from being infected and shedding and infecting others? And how long does it last? So assuming we knew all of that, I think it would be really important to be able, there's a whole field called seroepidemiology, which just studies antibody levels of diseases and how you can prevent disease in a whole population just by knowing that. So for example, go ahead.
Well, no, I was just going to ask, you said if we knew all that, but of course we don't know all that. We don't know yet what the presence of the antibody does or doesn't confer. How long, in your best professional estimate, and I understand, I'm not asking you to be a fortune teller here, but how long is that likely to take before we feel like we've got a better handle on what it does or doesn't mean to come up positive on an antibody test?
Well, I know, and Dr. Kong may bring this up as well, but I know that in our lab, and I'm sure this is happening elsewhere, we already have the capacity, at least in theory, to build out within the next few weeks the ability to detect antibodies that inactivate the virus, which is really important. Those are called neutralizing antibodies. They neutralize or inactivate the virus. That can tell you, at least in the test tube, that there are antibodies that will prevent the virus from replicating, which is important to know. We have that now, but go ahead.
I'm going to use layman's language. Forgive the interruption, because this is important. So we are very, very close indeed then to being able to identify whether or not the antibodies inactivate the virus, which in layman's language I would describe as keep you from getting it again. Is that a fair layman's phrase for what you just described?
Possibly, yes, in the test tube. So what we need to do now is measure them in people over time to be sure that that's exactly what those antibodies are doing.
Let me go to Dr. Kim and then to Supervisor Ellenberg, with the goal of closing this one out at 2 o'clock, because I know we've got some scheduling challenges. Dr. Kim, the question that I asked again was, if we could ramp up our testing capacity, what would the greatest benefit, what would we learn, what would you learn that would be helpful and important going forward in fighting the virus? So if we had 10 times the number of PCR tests or 10 times the number of reliable antibody tests, why would that be a good thing? That would be great, because why?
Yeah, absolutely. And I'll start by just saying that I echo Dr. Maldonado's sentiments on that. Just understanding where the virus is in the population. I don't think we've done enough testing yet to really have a good handle on that. And it is going to take more to get there. Being a little bit more granular in terms of use cases, for example, we do have a lot, we think about frontlines workers as healthcare providers, first responders, but the fact of the matter is we have a lot of other frontlines workers too, working in grocery stores, delivering our packages every day as we shelter in place. These individuals really, there's a whole other community that hasn't had as much access to testing as some of the people who are directly interacting with infected individuals. but that and as a result, we don't have very much information on infection rates in these other individuals who are out there and in the community. And so that's an example of that's a little more granular about an area where we could really use more data to inform policy about whether or not we're really ready to take next steps in terms of opening up our workforces even more and relaxing some of the sheltering policies. And I think if you just sat down and thought through it, there are lots and lots of pockets of information gaps like that. That would be really great for more PCR testing.
Dr. Kim, I just want to tease out for a little more clarity for me at least. You said we don't know, quote, where the virus is. And I gathered from your subsequent comments that that could mean we don't know where the virus is geographically, as in Palo Alto versus Gilroy, or among various categories of folks by age or by ethnicity, or it could mean by various occupations or occupational locations, meatpacking plants and or long-term care facilities. Is it all of the above? When
It is all of the above.
Okay, go ahead. I'm
yeah,
sorry.
absolutely. Geography, demographics, occupational, all of the above. And I'll say, let me make sure I reframe that a little bit, which is that we have some general ideas, right? Based on who's coming into the clinics, the patients that Dr. Maldonado is seeing. We have some general ideas, but if you look at the policy decisions, for example, Scott Morrow, the San Mateo the health officer, made an announcement this morning, I believe, about we're going to the next phase and aligning with state policy. But we don't know that those small business owners, these restaurants that are going to be doing takeout and curbside pickups that are going to be reopening, we don't really have a lot of granular information about what kind of transmission rates those folks might be responsible for or exposed to themselves. That's like that those individuals haven't necessarily had access to testing to date. So there's a little bit of a disconnect there between the data we have and the policy decisions that are being made. And I think if we can figure out how to coordinate testing with the policy decisions that are coming up, that we could have a more sort of structured and informed approach to making some of these decisions. And I'm not necessarily recommending that as a specific use case, but just to highlight an example of how we can fill in a little bit more of the gaps in the data to result in at least better decisions.
Thank you. Please do, Supervisor Ellenberg.
Follow up on that, but first, Dr. Maldonado, I just want to recognize and thank you for the presentation that you just made. I want to learn from and work with women like you every day. I just admire the straightforwardness, the clarity, the competence. I really appreciate the way you laid out the information with no holds barred. Thank you for that. This question is really for either or both of the doctors. Dr. Kim, you're making some suggestions about policy and strategy. What would you recommend that Santa Clara County put in place in testing or surveillance strategies to be as effective as possible, given the current limits on testing science and availability? How do we maximize what we can do?
Yeah, that's a great question. And, you know, this is, I'm gonna hesitate from fully answering it, is what I'll say, because there are such important factors to consider. Not just, you know, I'm presenting most of my thoughts from sort of a scientific mindset, but trying to connect it to policy. But the reality is that, to go back to some of the points that both Dr. Maldonado and I have been making around supply chain, these are really critical components as well. And what we don't have really great visibility into from the front lines is how much supply chain is there. how much test reagent is coming, and do we have guarantees that we're going to have certain numbers of tests? Can we get more guarantees around personal protective equipment that's needed to protect the people who are conducting these tests? And this is where I can't claim that any of us have sufficient information to actually say, yes, we should deploy this number of tests and we should prioritize them to these particular individuals. I think that requires a set of key opinion leaders to really come together with manufacturers, with public health officials, and also non-public health officials, public officials not in the health sector, who are thinking about some balancing these decisions with the economic needs to get people back to work and to really
Exactly
come
where
to
we
a whole.
are.
And yeah, that I think that's how we have to come together.
Dr.
So-
Maldonado. wanna
Yeah,
add
sure.
anything?
Yeah, so we just a few weeks ago received a generous gift from Priscilla Chan and Mark Zuckerberg here at Stanford. I'm leading the effort here at Stanford with my colleague George Rutherford at UCSF to exactly try to answer that question. Obviously, it's not enough to really answer the whole question, but we're using statistics and epidemiologic sampling around the 6 Bay Area counties, and we're working closely with all the counties, including with Santa Clara, of course, to try to do a sample of each of the county populations that matches the demographics of that population to follow them over time. So we're going to do one-time testing of PCR and antibody from 4,500 general population volunteers and 3,000 healthcare workers from our systems, from San Francisco General, UCSF, and Stanford, but then the general population of the 6 counties. And we want to follow them on a monthly basis until December. And we're really trying to stratify this so that we reflect exactly all the things that you mentioned around occupation, age, other demographic risk factors. How do we do that in a way that we can actually try to identify changes in infection rate over time? So we have spent a lot of time thinking about that. And all the statistics and epidemiologists that have worked with us are fabulous and have done a great job. There are obviously hotspots like skilled nursing facilities and jails that we're going to avoid, because those we think need to be done separately, because those we know are going to be at risk and should be done on their own. But we're looking at general populations, for example, areas in East San Jose or in the south of the county where we haven't, those people who can't come to Stanford or maybe even to the Valley Medical Center. And so trying to build that out so that we can work closely with public health to give them the information we have and share it in a transparent way, and see whether that can help identify hotspots. But the issue that Dr. Kim brings up is critical. We're still trying to figure out, are we going to have enough? Can we do it in real time, or will we have to batch those tests over time if we run out of supply? So I agree. I think, there is a way to do it if we have the capacity to guarantee supply over time. We've been, again, working with our own leadership at the governor's office. We've also advocated to the governor's office that they do the same thing, that they give us some guidance. California is one of the biggest economies in the world, and we should be able to have some kind of a insight into what these industries are able to tell us.
Thank
Or
you.
repurpose our current industries. With the amount of manufacturing here, it would seem to me almost in a wartime model, we should be able to repurpose or retool some of our partners here to be able to produce these items. And I'll be curious to know when we have the next panel if any of those conversations are already happening between county staff and potential manufacturers. Thank you both very much.
Sure.
One last question for the two of you. And again, I know we've got some time constraints that we want to respect. So let me start with you, Dr. Maldonado, and then go to you, Dr. Kim, before we go to our next panel. And that is, if you could share your thoughts about the relationship between testing, test results, and potential medical interventions, by which I mean prescription medication. They're, as you know, at every level, from the national on down, there's been talk about what might or might not be helpful, useful medical intervention. The latest conversation seems to be focusing on remdesivir, although I gather there's a range of views about whether that would be an intervention used earlier or later in someone's COVID-19 experience. So thoughts about the relationship between testing and the potential use of prescription medications as we move forward? Dr. Maldonado?
Yeah, absolutely. And I spend a lot of my time. We also, and in our own facility, we have inpatient and outpatient trial settings. And I'm one of the people who's running the outpatient trials because we're trying to rapidly find repurposed drugs that we can use for treatment. But certainly knowing if somebody's infected, you could at least get them to shelter at home, get them some symptomatic treatment, keep them at least isolated so they don't infect others, make sure that they recover well. The remdesivir story is an evolving one. It is a useful drug. It's not the only drug that we think will eventually be helpful, but it is a drug that probably works best right now in its current formulation for people who are hospitalized. So we're studying a number of other drugs. I was just on the phone this morning with the National Institutes of Health, and we're trying to collaborate across many institutions to build out more therapies, but all of them, the entry point for all of them is a test. So in order to be in the test studies, by and large, you're going to need to know that you're infected, because you don't want to, even if as safe as a drug is, you need to know what the end point is. And if you don't know if the person's infected or not, it's not going to be a helpful study.
Thank you very much. Let me go to Dr. Kim. Any thoughts on that subject, Dr. Kim?
Yeah, in addition to the things that Dr. Maldonado just mentioned, in the real world, in terms of how we normally operate, a lot of times, the therapies, I think knowing that there's sort of a backstop there, that if you do get infected, there's a way to manage the illness, provides us with some security that might lead, it's enough of a buffer that you might not need to treat or do the testing quite as aggressively. And I think that we're all holding out hopes that some of these therapies will be approved and have the clinical impact we need to sort of reduce this hyper-vigilant mode that we're currently in. That said, I think that we have to be really cautious about making sure the evidence is emerging and that we're actually really rigorously evaluating the outcomes of these clinical trials and not being too quick to accept them as the cures we hope they are. And so it is likely that the testing we're going to need to continue to be vigilant through the testing to try to control the disease through behavior, and rather than controlling it through therapies until we really know that the therapies are effective.
Thank you very much. We are up against a 2 o'clock time deadline. Dr. Maldonado, Dr. Kim, it's rare that I say this, but I want to give you the last word. So Dr. Maldonado, what last thought would you like to leave with us, if any, to help inform our thinking and our work going forward?
Yeah, I just want to, again, I think I've mentioned most of it, but I want to just thank you all for bringing attention to this issue at a high level in the county. This is an important county. It's one of the larger counties in California, the largest one in the Bay Area. And I think the population is very diverse. We have very high-end, high-tech, well-resourced people, and we also have health disparities throughout the county. And I think you have a great bully pulpit here to really start making some differences in what happens around the country by example. So thank you for this opportunity. And I do think we will be successful. I think we've done a great job overall in keeping the epidemic at bay as compared to other parts of the country, but some challenges remain. And I think with your leadership, we'll be able to address those. Thank you.
Well, thank you. And thank you again for being with us today. Thank you for sharing your knowledge and your insight. And thank you for the work you're doing. Dr. Kim, a last thought, a parting word. Don't forget to remember this. What would you like us to remember?
Yeah, and I'll echo the thanks for the leadership, for opening up this conversation. I think that one of the challenges of moving so fast and responding to the urgency of all this is communication. This is truly a crisis and an emergency response is needed. And we need to be coordinated in our response to be maximally effective. And there's urgent need for that effectiveness. The conversations, both at the county level and at the state level, even the federal level, I think we're finally starting to get there in terms of the coordination that Dr. Maldonado was highlighting is so badly needed. A lot of work to do still, though. So we need to continue the conversation to make sure we are all doing the best things we can for the communities that we all live in.
And I'll say thank you to you as well, of course. And we appreciate both your presence and your insights today, as well as the work you're doing out in the field. All right.
Thank you very much. Really
thank you.
appreciate your time
Thank
and
you.
information.
Thanks so much. Bye-bye.
Thank you, Supervisor Ellenberg. And Supervisor Ellenberg, I just want to check in with you that you're able to lean in and get your questions raised and your voice heard, given the technology limitations today. So far, so good?
No problems.
Thank you very much. That takes us to the second of our two panels. And as I mentioned earlier, this is a two-person panel as well that is designed to focus more on the operational aspects of testing, including strategies for increasing testing capacity and availability, access for residents of our county, and trying to assess and address some of the practical or logistical challenges that may exist, and some of which were referenced in the earlier conversation. To that end, we have with us today Dr. Marty Fensterscheib. Dr. Fensterscheib started just last week as the testing unit director for the county's Emergency Operations Center. He, however, is well known to those of us in the county because he spent 29 years in the Santa Clara County Public Health Department and served as the county's health officer from 1994 to 2013. I've had an opportunity to work with him a great deal over the years. And Dr. Fensterscheib received his master's in public health from UC Berkeley and is also a board certified pediatrician. Also with us, and Dr. Maldonado mentioned this earlier, we're very pleased to have Dr. Christina Kong. Dr. Kong is the vice chair and medical director of pathology and the clinical lab at Stanford Healthcare, has been since 2016. She's also a member of the California Testing Task Force since it was founded last month. She serves as professor of pathology at Stanford's University Medical Center, and she received her MD from UCSF in 1992, which is also where she did her fellowship and residency. So let me welcome them both. And I see Dr. Kong visually, and Mr. Fensterscheib, are you on the line as well?
With Dr. Cody and Dr. Smith, and my co-presenter, Key Lee, who's on our testing team. So we have a short slide presentation because there's a lot of information that we'd like to get to you. So we're going to put that up.
Then we'll
I have
say
my
thank
mask on. I have my mask on, so I'm feeling I'm a bit muffled, but we do have a room full of several people, so I need to leave it on. So is that okay that you can hear me?
Yeah, absolutely. And Ms. Ellenberg, I'll look to you for a nod or a shake of the head, but I'm hearing Dr. Fensterscheib loud and clear, notwithstanding the mask. Yes?
It's just fine.
Okay. Okay.
Thank you. Go right ahead, doctor.
Okay, so thank you both for having us here today to present this information. And it's basically the progress to date on our COVID-19 testing. And we basically just began our work, as you mentioned. I mean, it seems unbelievable, but today is Thursday. We started our team, put together a team very quickly on Monday of this week, and we've accomplished a great deal. I want to first thank our team, if they're listening, and even if they're not, for all their work so far. It's an incredible team that have been pulled from other places to do this work and to actually identify all of the barriers and issues around what we can do to augment the testing capability in Santa Clara County. And as I said, I will be joined in my presentation by Key Lee, so I have the first few slides, and then he will finish up, and then we can be available for questions. So in this very short time, we have developed a strategy for increasing our testing capacity in the county, and have really already, even after a few days, begun to implement several of our deliverables to get us to where we really need to be. So maybe for everyone's benefit, can we go to the first slide? So for the benefit of everyone, and especially me, I just wanted to see how we got to where we are today. And so this slide is basically a history of all the testing that has been done so far. Are we good? Okay. With COVID-19 being the first case in Santa Clara County at the end of January. And that's when we began our containment strategy. So testing was very restrictive at that time. As you remember, we were only testing symptomatic persons that met very strict criteria as set by CDC. And that related initially to travel and then to symptomatology. And the testing was initially done at the CDC. So it was very limited. So you can see on the chart that there was not much testing done initially. The first local testing really wasn't very successful here in Santa Clara County due to a number of issues. There were some flawed reagents that were sent from CDC, and so that made it difficult for us to actually do the testing adequately in Santa Clara County. It wasn't until early March then that we've had evidence of community-wide spread in Santa Clara County, and the cases began to increase rapidly. So containment, which again, the first strategy in any outbreak to try to find cases, test them, and test contacts, wasn't working anymore. It was out of hand. The cases were increasing rapidly within the community. The healthcare system countywide was extremely stressed, as evidenced by the numbers of people that were hospitalized and the number of ICU beds that were being used. So again, we moved from containment to a new strategy of mitigation, which we all know, which was initiated as we began realizing that we couldn't put out all the fires that were rising up as cases in our community. And then to that end, the first shelter-in-place order, again, and I think that was maybe in the whole country, was issued in mid-March. And the whole idea, again, as you know, was to try to keep people at home, to remove the fuel from this rapidly spreading virus. So if you think about it as a fire, we removed the fuel to that fire, and that's by keeping people at home and keeping them from spreading the disease from one another. This has been really successful. Cases have been decreasing over the last 2 months. However, really, the testing. I'm sorry.
Excuse me. I'm going to interrupt and ask that we stay focused on the testing rather than rehack the flatness curve effort, please.
Yeah, I'm getting right into testing. It's just going right there right now. I just wanted to. Okay. So anyway, our cases have been low, and we haven't been doing a lot of testing. So that's the issue, that testing has had a guidance where only symptomatic patients, and even the asymptomatic contacts to cases who were quarantined at that time, were not tested. And testing levels for that reason have remained very low at 1,000, about 1,000 a day, sometimes more. So the mitigation has worked. The healthcare system has been unburdened, and the hospital and ICU beds are available. And as we start, let's move on to the next. As we start thinking about easing the shelter-in-place order and thinking about what that means, doing so will begin fueling that fire, and more people are going to be exposed to the disease, and we're going to start seeing cases. So we had talked about the 5 indicators that have to be in place and being looked at so that we can move forward. And you can see number 3, obviously, is increasing testing capacity. as well as contact tracing and case investigation. So we have set a short-term goal of 4,000 tests per day. However, our ultimate goal is really to try to make testing easily available to anyone who wants to be tested that is at risk because, again, of potential exposure. But getting to that goal is going to take some time. But again, testing, as we've heard, testing per se is really not helpful to us in doing that easing of our shelter-in-place order unless we actually test those who are deemed highest risk for exposure and the most vulnerable in our community. And whether that's, again, where they live or, again, their own living situation or health conditions. And we know that our most critical areas for this are in our East San Jose area, parts of our South County, and certainly pockets in Mountain View. And because of wanting to increase our testing capacity and move away from just looking at symptomatic people, we've had to begin looking at a revision of our testing guidance. And that revision has been completed and will be issued shortly. And this emphasizes expanded and focused testing. And so now I have a slide up, which basically shows you the guidance and identifying clearly where we want to focus. And if you look at that, let me just get mine. And if you look at that, we certainly at the top are looking at symptomatic cases, and we will continue to have to test people who are symptomatic. And as we begin looking at who is now coming down with symptoms and has COVID-19, we will again be looking at a large number of contacts that have to be investigated. So clearly, as we test, we also need the capacity to follow up on all of the asymptomatic cases that will be identified through that contact tracing. We have a number of other very high-risk areas. The areas such as the jail and custodial settings, the skilled nursing facilities, again, in a non-outbreak setting situation, and other congregate care settings. And what we have done in this guidance is not only identify those areas, but have also identified the frequency at which we feel would be appropriate for testing them. So it's not a one-time test that for all of these individuals, we are going to have to test repeatedly. And I know that question has come up in the last panel, but for example, in skilled nursing facilities, we are looking at testing the residents once every 5 weeks, or on a rotating basis, about 20% of them each week. And I won't go over all of those, but again, it's a matter of focused testing. It's a matter of frequency and doing it more than once. And it's a matter of working with the entire community, the community health partnerships, and as Key will be talking about, all the healthcare system in dealing with this. But the first thing that we did was revise the guidance so that the physicians and the healthcare professionals in the community who basically have been following an initial guidance of pretty much treating symptomatic individuals or testing symptomatic individuals are now going to see an expanded recommendations to test a vulnerable population in our community. But again, as we do that, we will start seeing a number of cases. Now, the 4,000 number, as we talk about, we will.
Forgive me, I need to ask you to move on. We'll come back to this, but we've got another panelist that I want to get to, and I want to make sure we have time for comments.
Okay.
We will come back to this slide, I agree.
Yeah, I'm done with that slide. I just want to mention that when we do test all of those people, our data shows that will require us to test from between 13,000 to 15,000 people per day in order to just capture those individuals that we consider high risk.
Thank you. Next slide, please.
Thank you, Marty. Good afternoon, everyone. This is Key. I'll try to be brief, Supervisor Sabidian. the new testing guidance is foundational, and it'll help us as we prepare to shift to consider shifting to a new strategy. And this is all about setting a sort of different set of expectations. What we're trying to do is to say that symptomatic persons should expect to be tested or be able to access testing. Contacts through contact tracing staff should expect to be be tested. Healthcare workers and first responders. Not only should they expect to be tested, that testing should be easy. They should expect that tests would be scheduled within 24 hours and that results come back in 48 hours, and that there should be no out-of-pocket expenses. And this is also about setting expectations for our healthcare systems and our health plans. For example, I know that Stanford has tested a lot of their staff. I know that Valley Medical Center has tested about 6,000 of their employees. We have confirmed that Valley Health Plan is going to is working to ensure that all Medi-Cal members, VHP members, and Covered California members are covered. Employers are also making available, ensuring that their workers have access to testing. For example, the county, VTA, and San Jose are having a call with Kaiser tomorrow to ensure that employees who are members of Kaiser will have access to testing. And then cities and counties support the isolation and quarantine effort. And then, as a part of this, we're going to try to use the county communications machine that supported the shelter-in-place activity to shift the public narrative. And then finally, at the EOC, at the county level, we're going to try to orchestrate all of this as we shift, and then we have some specific roles for the county. Even though laboratory capacity, reagent supply is a concern for the long term in terms of the level of testing we want ultimately in the community, in terms of our short-term goal, we believe that with the 4,000 goal, we have sufficient laboratory capacity to meet that by May 31st. The real issue seems to be around specimen collection. And as you see on the screen, on the right side of the screen, these are how we categorize these different types of sites. We will have to rely on our healthcare and hospital systems primarily and our community clinics, but we may have to establish additional pop-up sites, testing sites only. To go into just a little bit of detail about our initial specimen collection strategies, we're going to try to drive demand for testing. We're going to try to work with our hospitals, our health systems to be able to meet that demand. And then for the county, I believe that we have some very specific roles. First is the congregate settings. And those are really broken out into three areas. Skilled nursing facilities is one. The public health department has already facilitated or conducted mass testings at 10 skilled nursing facilities. The ultimate goal is for skilled nursing facilities to be able to test their own staff and residents, and the public health department staff will sort of provide support until the SNFs are able to do that. Custody health will provide the testing in the custodial settings of the inmates and the youth and of their own staff, but potentially other staff in those settings. And then the county will have to determine how to operationalize testing on a routine basis and to support outbreaks at homeless shelters and other congregate settings. We believe that congregate setting testing, surveillance, and outbreaks will yield probably around 1,000 tests per day by the end of May 31st. Access for contact tracing. While the shelter-in-place order is in effect, we believe that there might be about 600 tests needed per day to support the contact tracing efforts. This will grow dramatically if the order is lifted, but we're trying to set up the system so that our contact tracing unit can easily schedule or help schedule people who need to get tested, either through their own provider or through pop-up sites that we establish. And then finally, the community health partnership clinics. As you know, there are about 16 of them. While their specimen collection capability is relatively small, in a couple of hundred, maybe 300, we think that working with them as trusted partners is critical to meeting the needs of certain underserved communities and neighborhoods. And for the last slide, I'll turn it over to Marty.
Thank you. And so in conclusion, we wanted to show you the map on the side, on the left side, and basically those hot zones are going to be the places where we are directing additional testing sites, and that's East San Jose, and one in South County and Gilroy area, and then a Valley Medical Center drive-through site, which will be set up in the Mountain View area to deal with the pockets of disease up in that area. But again, just realizing that we're all in this together, it's a collective effort, and it's not just the county, but everybody else. We have a number of things, as we've mentioned, that are underway now. The guidance is being finalized and will be sent out, and that will help drive the medical community to do more testing. We talked about the additional sites. Improving the county's testing portal is already up and running, and it will be a user-friendly place for somebody to go on and find a site and get the information on how to get tested at that site. The VMC mobile unit, again, we will identify where they will be able to go in order to hit pockets of high-risk individuals or congregate settings such as shelters. And we've already emailed out over 8,000 flyers to businesses, again, talking about the role of businesses in trying to encourage their employees that are on the front line to get tested.
Dr. Fenster-Scheib, I heard you mention, if you go back to the last slide before we go to Dr. Kong, I heard you mention earlier in your presentation pockets in Mountain View, but in the recitation of places where there might be additional testing coming soon and stood up, I heard South County, I heard East San Jose, I heard VMC, but I didn't hear much about the West Valley or North County. So can we look for some stepped up access in the North County and or West Valley?
Well, there are a number, and I don't have a list of the ones at VMC, the drive-through sites at this point, but we're going to expand one to Mountain View to help serve some of the high-risk areas up in that area. West Valley, I will have to get back to you unless somebody in the room knows.
All right. Well, I just, before we go to Dr. Kong, and I want to go to Dr. Kong right away, I will just point out that I understand, of course, going to areas where there has been the greatest impact and support that. On the other hand, if testing is designed to give us a true read on what's happening throughout the county, by definition, if we aren't getting our testing out to the entire county, then we're not getting a true read on what's happening throughout the entire county. And I will just leave it at that. If we could go to Dr. Kong, please, and say thank you again to the team for that summary. We will come back to it. And Dr. Kong, thank you for your patience. We're planning to take this conversation to about 3:15 before we go to members of the public for comment. What would you like to share with our Health and Hospital Committee about the operational challenges and opportunities going forward to ramp up testing, and your thoughts, if any, off the cuff on the presentation you've just seen? And as we say on the committee here, permission to speak freely, Doctor.
Okay, thank you.
Thank you.
Yeah, so can you hear me?
Loud and clear.
Just want to make
Thank
sure
you.
I'm not on mute. Okay, good. So as you know, the challenges to testing has to do with the testing kits first, and then with the testing equipment and testing reagents. And so those are the different components. And then the end part, which is getting the results out to the person who had the test done. As far as the testing kits, there's been the shortage of the nasopharyngeal swabs. We have been working with a 3D printing company in Redwood City, Carbon 3D, to validate 3D printed swabs, which would then increase our access to nasopharyngeal swabs. We're close to finishing that validation study. It shows pretty much comparable performance to a regular nasopharyngeal swab. And so that would actually make it so that we no longer have difficulty accessing the collection kit. Another good thing is that there's more studies coming out showing that mid-turbinate samples are about 96% equivalent to a nasopharyngeal swab, so it gives you access to other specimen types. NARI swabs, which would be self-collected, is about a 92% agreement with NB swabs. One comment is that the studies were done on symptomatic patients, so it's not quite known how they would perform in asymptomatic patients, nasopharyngeal swab versus alternate specimen types. And then there's, more studies being done on saliva collection and other ways of getting samples that are not reliant on having a nasopharyngeal swab. So I think we're getting a much better handle on the collection kits. The study that was done in Washington through the Everett Clinic, they also looked at transport media. So they looked at buffered saline versus the traditional viral transport media. And they showed good performance of the buffered saline, which is what we've been using at Stanford since fairly early on because of the difficulty of accessing viral transport media. I know in speaking with my colleagues at UCSF, they found that buffered saline sometimes doesn't perform quite as well when the specimen has to be transported, over a distance. But most of our samples, come by courier and we receive them pretty quickly. So we've actually had good results using buffered saline. And so we've actually purchased a lot of tubes and we fill those tubes and create our own kits. As far as the testing reagents, that's something where the supplies are highly variable. We were getting a fairly steady supply of reagents from Hologic, and then they had a manufacturing glitch, which then, made a dip in what they were able to provide to us. Because all the companies are actually running, as fast as they can as well. So if they have any, problems in their supply chain or in their manufacturing, that impacts, everyone who's doing the testing. So to try to deal with the testing reagent issues, we have our own in-house FDA EUA assay, which we have brought up. We started testing in early March. I think March 4th was about when we started running that test. We're trying to actually expand our capacity with that test. That one runs across 3 different RNA extraction platforms, 3 different PCR platforms, so it makes us less reliant on a single supplier. And we're actually working on pooling, which would then let you take multiple samples and be able to run, use the reagents for a single test on it and to be able to, greatly increase capacity. The challenge with pooling is that it does slightly decrease the sensitivity of the assay. And we're looking at what that, what that means. Because right now the PCR platforms, they have a sensitivity, up into a cycle threshold of, high 30s, about 40. But the question is, do we have to detect that high? What does it mean when somebody has the low viral load, high cycle threshold? Are those patients contagious? Is that virus that we're detecting, transmissible or not? So, we think that we can get to a cycle threshold detection of about 35 with the pooling technique. And we hope to have that, running by the end of the month. We're also talking with UCSF and CZ Biohub, to talk with them about pooling as well, so that we can actually try to bring it up, in more than one location. It becomes challenging to bring up a technique like that in other non-academic type labs because of the equipment that it needs.
Thank
And
you.
it looks like you're about to ask a question. Yeah.
And thank you. My question was, and if you're able to make that progress by the end of the month, what does that do to kind of bottom line it again to your ability to ramp up the number of tests there at Stanford?
So our goal is to do pools of 8. And so if you can do pools of 8 and on that platform, we're hoping to be able to do about 1,400, tests with that platform. So it just kind of, it'll just exponentially increase it. We're looking at automated pieces of equipment that would actually make it less hands-on time, because part of it right now is that it just requires a person to sit there and do the pooling. And so we're looking at a piece of equipment to see if we can automate it. And that kind of gets to the question of how many more can you do per day. But we're hoping with pooling that we can handle the asymptomatic testing that's been happening a lot.
Doctor, you had me on the edge of the seat when you said, how many more can we do per day? And then I didn't get the answer to that question. Is there an answer to that question?
Well, the reason that I didn't give you an answer is that it will depend on how well that piece of equipment that we just asked to be delivered to see if we can automate it. And so it would increase by a factor of 8. And so let's say, you know, right now on our in-house assay, we can run about 400 a day. So 8 times 4, it would increase it to 3,200. If we're able to use a piece of equipment that lets us pool more easily instead of by hand, then hopefully it'll increase it more.
Thank you. And did you have any reactions to the slide deck presented by Dr. Fensterscheib and Mr. Lee?
Yeah, I mean, I think the question of how often do you test, it's a really good question because, as you know, we've tested about 12,000 of our healthcare workers now. The PCR positive rate was extremely low. The IgG serology positive rate was also low. It's about 1.5%. And so now that we have that data, we're trying to figure out, you know, what is the best strategy for testing our healthcare workers moving forward. We think that retesting everyone on a regular basis may not make the most sense. And so we want to try to identify, you know, what are true risk factors for people, you know, to be tested. And since we have all that information, we can see, you know, were there certain groups of people, you know, based on their occupation that were more likely to be positive, or was it more based on where they live? You know, those kinds of things. And so we actually have a meeting coming up next week with a group of people who've been thinking about, you know, how can we actually develop a more nuanced strategy to testing? It's not something we have an answer to right now, but it's something that we have to try to figure out. And we're involving epidemiologists as well as, you know, data analysts to try to get at that question.
Thank you. What I'd like to do now, Supervisor Ellenberg, is if you have a question for Dr. Kong specifically, take it. But if not, I want to go back to the slide deck, raise a couple of issues with Dr. Fensterscheib and Key Lee, and then go to you, Supervisor. Which order would you prefer?
My questions are also directed at Dr. Fensterscheib. Sorry, Marty.
Dr. Kong, if you would stay with us, please, because I do want to come back to you and ask you specifically about what you think you're learning from being a member of the governor's task force and what potential there is at the governor's task force level to expand testing in our region in particular. Right now, what I'd like to go back to Dr. Fensterscheib and Key Lee and ask first that the slide be placed up on our screen that shows the growth in testing over time. Dr. Fensterscheib, can we make that work?
Yes, we're trying to get that up right now.
Thank you.
I can pull that up as well if you're having difficulties.
We have it, I think. Yeah, we're good. It's coming.
Is this the slide?
And that's the slide. And I just want to pluck out a couple of numbers. As I read the slide, a month ago, we were at about 650 tests a day. Now, a month later, in early to mid-May, we've doubled that number and we're more like 1,300 or even better a day. So far, I want to know, is my analysis or my read of the chart correct, accurate, on point? Yes?
Yes, you're absolutely
Thank
right.
you. All right, then if we are targeting 4,000 tests a day, however, by the end of this month, that means that we have 2.5 weeks to triple the current daily testing. Is that still a goal that you all think, while challenging, is realistic? Because
Absolutely.
tripling our, okay.
I'm sorry, I didn't mean to interrupt you, but yes, we do. We're confident because we think we know the lab capacity is there. And when you look at those, again, early on, we were just testing people that had symptoms. So when we really expand it, we have the capacity and we have the information and guidance going out to the community. So we will be able to do this.
All right, now, if you will go to the slide that lists the criteria for testing, please. Thank you. Here's what I want to say, and please feel free to push back. And if Dr. Kong has thoughts, I want to hear from her, and I definitely want to hear from Supervisor Ellenberg. My concern is that if the current thinking is, gee, we have the capacity, we just aren't getting the right folks to that capacity, and we need to increase the number of folks who are participating in the available testing. I think that to make that happen, the criteria has to be concise, it has to be clear, it has to be consistent, and it has to be comprehensible. And the tests also have to be affordable, so I'm pleased to see the notation that no one need take dollars out of pocket in order to access a test. But as I look at this chart, it's detailed, which and it's certainly thoughtful, and I want to underscore that. I get it, but I'm imagining trying to communicate this to the general public. I also understand that it changes with time because our health situation changes with time. But if I could say to somebody in crisp, clear language, if you're showing symptoms, working with others, or over 50, 60, 70, whatever the age is, that's pretty crisp, and people would know they could show up. But I'm just anxious, candidly, and I'll go farther. I'm skeptical that we're going to be able to ramp the numbers up with this level of complexity to the criteria. Thoughts?
Well, this guidance is not for the general public. So this is basically a guidance to the medical care community. As we said, just in looking at the skilled nursing facilities alone, we're looking at nearly 1,000 tests. And healthcare workers,
I understand
nearly
that,
1,000. I'm sorry?
Excuse me, Dr. Steb. I understand that initially we were anxious that we not have people who were perhaps not in need of the test overwhelm our very limited testing capacity. Understand it? Think it makes all the sense in the world.
Right.
But as we speak today, the problem is in order to chart a path back to normal, we need to get adequate testing capacity. That was one of the slides you showed us earlier. That adequate testing capacity has been identified as roughly 4,000 tests by the end of the month. And I am worried that now we're not going to be able to use the capacity you've already identified. So I want to keep underscoring the importance of something that is relatively consistent, even if facts on the ground change, so people can keep track of what the rules are to get a test, and that they can comprehend, and that's clear and concise. Because I am frankly quite anxious, as I say, about our ability to drive those numbers if we don't kind of cut to the chase and make it easy for people to understand what the criteria are and where they go. So back to you, and then I'll go to Dr. Kong if she nods because she has comments, or if she shakes her head, I'll go to Supervisor Ellenberg. So so I'll go to Supervisor Ellenberg after you respond, Dr. Fenstershot.
Okay, well, again, we've identified those at highest risk because I think that's what makes sense epidemiologically. I think we, again, have a message, the messaging going out to the public is going to drive demand. And those people, say, on the front line, will then be going to our pop-up sites or to their community clinics. And we've had calls already with the community partnership clinics, and we're going to help them with supplies and lab capability. So again, they've told us they can increase their capacity greatly. So I don't know, I could go out on a limb and say I'm pretty confident, but I am pretty confident that we can do that by the end of the month. And as I said, in moving forward, that 4,000 is just kind of an arbitrary number, and we're going to have to even go beyond that. But we've already put out information to the public and to the business community. So we've got to push demand in order to use our available capacity in our lab, which I think in our various lab sites around, testing sites rather, that I think are underutilized at this point, or have greater capacity, I should say.
I understand. I'm going to press you one more time on purpose, Dr. Fensterscheib, and you and I have worked together over a lot of years. You know how much regard I have for your expertise. I want to underscore the fact that I want the testing regimen, just as you do, to be driven by good science and good public health thinking. That being said, as I'm looking at the chart on the screen, which you've described as being a set of criteria that makes sense epidemiologically, if I remember what you said correctly, would you agree that it doesn't make sense epidemiologically if we can't actually get to our testing numbers because we can't get these folks to take the test in sufficient numbers?
Well, again, people basically need to be informed as to whether we want them to come in and who they are and make a decision whether they want to test. And so again, that's where we have to push demand. And so again, we've already sent out information to the community, and that's what's going to go out. It's basically going to be saying that testing is now available, free and easy. Schedule a test today. And point them to our website to make the appointment. So right now, again, we haven't done anything for demand. And so I think it's not going to be that difficult in pushing demand over the next week or so to get those people into these testing sites. It's not going to take much to get up to that 4,000 number.
I certainly hope you're right, but I want to go back to my question, which is to lay out a category or a set of categories that are priorities for testing makes sense epidemiologically if you can get them to test. But if it turns out that despite our best efforts, that group of folks is insufficient to push our testing numbers up, we're going to be sitting at the county saying, gee, we're not ready to take the next steps forward. And we're going to have to look at another set of criteria. Is that a fair assessment or not? And if you have a different view, that's okay. But that's how it looks to me as I consider the possibilities.
Well, again, I mean, this is the group of people we want. Now, will we get all the people that are on our high priority list? I would say no. And so we're not going to turn anybody away. And people that want to go get a test will be able to go get a test. They're not going to be turned away. But I think the idea is to push people out to our sites, which are being underutilized at this point. So it's not going to be an all or nothing. It will be people that want to get tested can go get tested, but we would prefer, in order to help us make these epidemiological decisions, to have the people at highest risk. But it's not limited to those people.
Well, that's an important distinction, and it's a little different than what I thought I heard earlier. So if I got a little more clarity, that's helpful. Could we go back to that chart, please? Okay. And what I don't see here, and I'm just saying I don't see it, is general public. And, you know, essentially what I heard you just say is that we're not going to turn anyone away, and which I took to mean anyone who wants a test can get a test. So I do think we need to be clear about that before we go to Supervisor Ellenberg. And if you want to take a minute to pull your thoughts together or put your microphone on mute while you talk to the rest of the staff, that's fine. But I think we don't want to walk out of this meeting unclear about who can or can't get a test in this new testing regimen.
Okay.
Maybe I can jump in. This is Jeff Smith. The chart you're seeing is the chart that goes out to the doctors who are in their clinics. But what you saw before was the advertisement that goes out to the public, which says anybody who's asymptomatic who wants to get a test can get a test. So if we want to clarify that more, we certainly will, but nobody's going to be turned away. This is really just a matter of saying to the doctors, we want to focus on these people, but if people want to get a test, they can get a test. And we'll have sites throughout the entire county, and we've decided that we can certainly work with Verily and Optum serve, but probably most of the drop-through or drive-through sites are going to have to be run by our delivery system, VMC, in the clinics, but they'll be in different parts of the county, not at VMC.
Thank you. Let me go back then to Supervisor Ellenberg. Thank her for her patience. And Supervisor Ellenberg, I have to step away for just a moment, but I'm going to leave it to you. Right now, your mic is muted. So if you want to unmute. There we go. Go to it.
Thank you. Let me kind of start with the testing site question, and to echo Supervisor Smidian's point on this chart. I agree that we need to make the tests available where people are. We need to be going to the skilled nursing facilities to test, obviously not advising people there to go to a site to get a test. Can someone confirm that we are going to be out where the people are?
Yes, he's going to respond to that, but we are. Go ahead. Do you want to say something? We are going to be at the site. We are going out there to do the testing.
Great.
Okay.
And let me ask, and this question is for Dr. Smith, just an overall strategy question. I really appreciate Dr. Fensterscheib's enthusiasm about starting on Monday and all of the things that are in place by Thursday. But why did this just start on Monday? Why did we not start this work a month ago?
Dr. Cody's going to respond. Dr.
Dr. Cody's here.
He just had to step out for a minute before you.
Oh, that's fine. I didn't realize Dr. Cody was on the line. Terrific.
Yes, she is.
Yes, I'm here. Hi, Supervisor Ellenberg. We didn't just start on Monday. We've been working at this for a very long time, and as all of our other speakers have noted, it's incredibly complicated because of supply chain issues, communication issues, logistics, many different sectors all trying to do something different: public, private, local, state, federal, et cetera. So we have been working the problem. We have actually been working the problem since early February. It's just that we've had enormous difficulty getting traction. And now that we have a lot of partners and a lot of capacity and a lot of need, we assembled a team to be strategic to ensure that we match capacity to need. And that's the work that's just gotten started, is the overall strategy part to make sure that all the pieces that we've been working on get melded together.
Thank you. I really appreciate that clarification. Let me stick with capacity for a minute, because I think it is still not completely clear to me what our capacity is, especially given the comments by Dr. Maldonado. What is the current daily Santa Clara County capacity for testing, given our lab equipment and supply issues?
Can you clarify capacity on which end, whether it's because there's several different parts to capacity?
To perform the tests.
So to perform the test, of course, you need the collection, and then you need the different parts of, right? So there's several different steps to capacity. Key, do you want to talk about the parts?
Yeah, I think in terms of the lab capacity, what we are trying to show in an earlier slide was that if with our initial goal of 4,000, we have more than sufficient lab capacity to meet that goal, lab capacity.
So
However,
okay.
Yeah.
Go ahead.
Right. Now, how long can we sustain 4,000 tests per day? I mean, I think that's a question, but I think we want to get to 4,000 tests per day. If we got to 4,000 tests per day, there is sufficient lab capacity in Santa Clara County to meet that goal. And I'll just move to the slide that has the lab capacity. So as you can see here, on March 31st, we had a very limited lab capacity. By April 30th, we got already to more than 4,000 tests per day. And by May 31st, we're projecting to be well beyond 4,000. And some of this is because The Valley Medical Center has added a testing machine. They've increased their capacity from about 300 to about 1,000 tests per day. The Public Health Department its lab is going from, once they get their machine sometime next week, I believe, will go from about 100 to about 600 to 800 tests per day. So the lab capacity.
Sorry, let me just get clarity there. When you say capacity, do you mean machines or supplies?
Both the machine and the reagents. We have sufficient machines and the chemicals and perform the test.
And the swabs?
4,000 per day. How long we can sustain that is sort of another thing that we have to monitor.
So I remember the report for the May 5th Board of Supervisors meeting referenced that the Public Health Lab would be expanding capacity by mid-May. I realize that this is one of the smaller labs, but has that planned expansion occurred?
In process.
Yeah, yes, that is in process. The Public Health Lab currently has a capacity to run about 100 tests per day, and they're in process of expanding that to about 600 to 800 tests per day.
By when, excuse the interruption, but by when do we think that's likely to happen? I just want to make sure Supervisor Ellenberg's question gets a firm answer to the extent that a firm answer is possible.
We don't have a firm date, but we're happy to get back to you.
We've been told that it's imminent. We've been talking to the lab director, and they're just waiting to ramp up. So we don't have the exact date, but we will let you know.
Yeah, I just got a clarification from the team. They said the machine is coming next week, and by May 25th, the lab should be ready to utilize that machine.
Okay, so we're talking about hopefully another week. And will you please confirm through an off agenda or just a simple email to the board members when all of those pieces are in place and the lab is up and functioning?
Absolutely.
Thank you. Let me ask about backlogs. I received a call from a constituent who was tested at James Lick and didn't receive his results for a week. What do you know about backlogs in general at the community sites? How quickly should patients expect to receive their tests? And what are the performance expectations or standards that we should be holding these testing providers to?
I believe the James Lick site is the OptumServe site. The state runs that site, and so we'll have to confirm with the state. I think the expectation for the community is that it is, of course, quick. I think on the slide that we have this expectation that it would be 24 to 48 hours from the time that someone takes the test that they should receive a result. And then we're going to have to monitor that and across the community and try to sort of facilitate every lab getting to that goal as quickly as possible.
Okay, and I would like, go ahead.
I can comment on the turnaround time question.
Thanks, Dr. Khan.
Yeah, so the reality is at Quest and LabCorp, where there are a lot of specimens going in, the turnaround, they do prioritize specimens depending on if it's symptomatic or asymptomatic testing, and if it's outpatient or inpatient testing. So I think their turnaround time has been running about 4 to 5 days, for outpatient testing. At the worst time, their turnaround time was up to 12 days. It hasn't been, that bad for quite a while now. And I mean, a comment on our turnaround time as well. I mean, our goal is 24-hour turnaround time, but for asymptomatic testing and for lower priority testing, it has been up to 3 days at times. So we do prioritize how we run the tests and which ones are done first.
And do you let patients know what their priority level is when they test? And do we do that as well so that people can manage their expectations?
That's a good question. I actually don't know the answer to that, if we do let people know what the expected turnaround time is or not.
I highly recommend it, and certainly recommend it for the labs over which we have control. There's already so much uncertainty and anxiety. Anything that we can do to help people manage their expectations, I think we should be integrating. The chart that showed the priorities for testing focused largely, to a large extent, on locations, congregate settings, healthcare workers. But with the data that's showing that in our county and certainly in other communities, the disproportionate cases among African American and Latinx populations, how can we and should we incorporate this in informing our local testing outreach and prioritization of some groups of essential workers groups or neighborhoods for testing? With the new zip code information that has come out, and thank you, I appreciate that further level of detail. We really are seeing very clear ethnic breakdowns and disproportionality. How does that fall into the priorities system?
Hi, Supervisor. You're absolutely correct, and that fits very highly on where we are recommending for the newest sites and the additional sites to be placed. So for instance, we look at the maps and see where our cases are and where our most highly vulnerable population, as you know, and we've identified certainly East San Jose, and so we directed another site there. We identified Gilroy, and we directed another site there, and some pockets in Mountain View, and so there will be another site there. So that capacity being there, but then it requires all of that information and outreach to go out to the community. So the messaging is very critical, and culturally sensitive messaging to inform people that they need and can be tested. So we are on board. We basically are outreaching those communities at higher risk, in addition to the congregate care settings where we know they're at risk. But that's the makeup of where we want to focus most of our testing at this point.
Thank you so much for that, and thank you for recognizing that the way the message is distributed is important, and the messengers are important. So using, again, our CBO partners, using our partners, if appropriate, from the Office of Immigrant Services, making sure that we're able to convey the vital importance of this testing and the low risk in terms of other very legitimate concerns that folks might have. At this point, I want to thank you for the slides on local testing strategy and groups. This addresses many of the questions on higher risk populations that I sent out in a memo attached to this agenda. So what I'd like to do in the interest of time is follow up on additional details following the meeting with a written off-agenda report on the testing strategic plan to be shared with the full board, please.
Thank you. Thank you, Supervisor Ellenberg.
Thank you all very much.
Let me go back to Dr. Kong and ask if she has observations, as I had indicated I would, about the role of the state and the state task force that she's serving on in terms of ramping up the number of tests and capacity in the county, understanding that our county staff is still focused on trying to get more people to take advantage of the capacity that we already have. Dr. Kong, thoughts, if any?
Yeah, so the state has been focused on making sure that there are sufficient supplies to do testing. And so they've been purchasing the different collection kits. So they have about 20 million on hand with plans to continue purchasing more. They've been distributing it to different medical facilities and counties as needed. They're also working on purchasing testing reagents and partnering with labs, such as with us at Stanford, when they know what reagents we need and what other labs need, working with the companies to try to ensure that we have a continuous supply. And then the OptumServe sites. And so as those sites reach capacity, they're also working with the different counties to try to put more OptumServe sites in place as needed.
And if our county staff could comment on whether or not that state effort around acquiring testing kits and reagents has benefited Santa Clara County to date, or you anticipate that it will in the near future?
Yes to both, Supervisor.
And could you give me now I'm going to be the one who says, could I get a little more detail on that, please?
I'm told, again, I'm unaware of all of these details, but I'm told that we have received already 15,000 kits from the state this week. And again, we continue to put our orders in, so we are receiving these on a kind of weekly basis. But we are, through the state system and the Office of Emergency Services, we are making those requests on a regular basis. And we take what we can get, but we are happy to receive anything that they send us.
Thank you. And I would just ask about some of these supply chain issues. And this goes to the information that Dr. Kong shared earlier. And thank you. It was helpful as we were talking about 3D printing capacity and nasal swabs in particular. I am asked by my constituents fairly frequently, for God's sakes, we're in one of the most prosperous counties in the country, if not the world. We are the heart of Silicon Valley, as the overused expression goes, and yet somehow we can't get nasal swabs. What's that about? Is there an answer to that? What's that about? How hard is it to make a nasal swab, as an example? And why can't we just say, we're on it?
Well, again, it's been challenging, and up until now, we've had to depend on those specialized swabs for the nasopharyngeal collection. I don't think we had it mentioned. I actually had a prop here, which I didn't get to use, which was a nasal swab, which I was going to swab my nose for you, but I didn't get to do that. So
we thank you for that, by the way.
Yeah. So basically, what I'm saying is that we can use some much more available common swabs that can be self-administered by the patients on a large scale, where it requires less PPE. It's easy to facilitate faster throughput, and basically, it's almost like a Q-tip, half of a Q-tip, that you take it yourself and swab each side of your nose a few times, and then drop it into a viral transport media. In doing that, we will be able to, I think, increase our capacities greatly. Certainly the community clinics, and talking to them about that, are excited about it. I know that the availability of those swabs is much better than the other swabs, and I think we have, I'm not sure. we have sufficient swabs.
Both the county staff and to Dr. Kong, let me just ask, have we more or less given up on the federal government playing a role in expanding our testing capacity, or is there still some room there to hope that we can get additional federal assistance?
So the state has been working directly with the federal government, and so the federal government did offer to help with some testing reagents, and the state's been coordinating the request for that.
So the chain of command effectively is, if we're looking for help from the feds, we should be working with the state and let them handle the relationship between the federal government and the state government. Is that your understanding, Dr. Kong, from your work on the task force?
Yes, because that way they can put in one large request that encompasses all the different labs' needs. And they've put up a reporting site where each of the labs performing COVID testing can report their results each day, and also report what platforms they're running on and what reagent shortages they're facing. And that gives the state testing task force visibility into what challenges are out there in supply chain.
Thank you very much. And we haven't talked much in this panel about antibody testing. Dr. Kong, and then I'm going to go to Dr. Fensterscheib and the rest of the team with him. Thoughts about the merits of antibody testing at this point or in the near future, the prioritization of antibody testing vis-a-vis the PCR tests. What are your thoughts?
So the serology test is best for performing prevalence surveys where you can get an idea of how much of a population has been exposed to COVID. If you want to know if somebody has a current infection, you really need the PCR test. There are a few other instances where serology testing could be potentially useful because viral shedding is highest when a patient is symptomatic, and as they're more days away from their symptoms, the viral load decreases. So a PCR test can be negative in somebody who actually has COVID. And in that case, the serology test could be helpful in making that diagnosis and guiding treatment. That would be, more probably in your inpatient setting where they're trying to decide, how to manage a patient. Serology testing can also be helpful in identifying potential convalescent plasma donors so that you can collect plasma from those people and use it for treatment. And then another, potential use that's probably more controversial is for people who had COVID-like symptoms back when testing was less available, and they want to know if they had COVID at the time or not. And so a serology test can help answer that question. But having said all of that, there's a lot of instances that serology testing should not be used. So it should not be used for return to work. It should not be used to guide PPE use for a healthcare worker. Should not be used to decide, duty assignments. And it should not be used to determine if somebody is protected against a future COVID infection. Because the tests that are currently available just tell you if you have antibodies, not if they're protective or not. And when using a serology test, it's really important to select a test that has very high sensitivity and specificity. The FDA now has gotten involved in serology testing, and so many of those disposable cartridge kits that were first available are now being pulled off the market, and the advice is to not use them.
Thank you, Doctor. I think your comments on instances in which the serology tests are not a useful tool is a helpful one, and I personally will want to go back and listen to it yet again. You did mention the potential for plasma donation, and I've seen some popular press reports, but I candidly don't understand the science or the medicine enough. Is that a real thing? Where are we with that?
Yeah, it is a real thing. And so the idea is that a person has developed antibodies against COVID. So if you harvest their plasma and transfuse it into somebody who has a COVID infection, then it helps them fight against the infection. And so there is a convalescent plasma donor program through the Blood Center at Stanford. And there's a website where people, can fill out a questionnaire to see if they may qualify. And we also have a document that talks about indications for serology testing, including the ones where I said it should not be used for it. And it's on the Testing Task Force website. And so I can send a link to it so that you can see it.
Thank you. But and staying with the plasma donation for a moment, you're telling us that the science there is fully enough developed and is robust enough that you can already conclude that this is a useful tool. Yes? Did I get that right?
There's enough cases where there's been shown to be a benefit that this is something that is used to treat, some critically ill patients. And, with COVID, so many things are moving so quickly that you don't really have well-controlled studies, showing the utility. But based on, seeing patients responding well, it is a treatment that is used. So they're basically running the study while they're collecting and using it to treat people.
Thank you. Let me turn to our county staff and team with Dr. Fensterscheibe in the lead on the question of antibody testing and where that does or doesn't sit in our priority queue. And then I want to go to Supervisor Ellenberg for some final questions or comments before we go to members of the public who want to speak and be heard on this item number 2. Dr. Fensterscheid?
Actually, I'm going to do this one because it's really an operational thing having to do with BMC.
Thank you.
Current,
For the record, this is Dr. Jeff Smith, who is our county executive. Go right ahead, Dr. Smith. Excuse the interruption.
so the current status of serology testing in our delivery system is that it's being used with severely ill individuals, sort of like Dr. Kong mentioned. And we have utilized the serum antigen-filled serum in a few patients in the ICU and very, very sick patients with sort of mixed reviews so far. But I think the numbers are so small in our use that it's hard to make any kind of judgment. And, you know, we're continuing to use that. So it's really, the serology tests are not particularly useful in terms of screening. So the outside tests to the community are really the PCR test. The serology test is useful for other issues, as was described by Dr. Kong.
Thank you to you both. Let me go back to Supervisor Ellenberg for some wrap-up comments or questions, and then we're going to go to members of the public who want to speak on this item. Supervisor?
Thank you. I want to thank all of the panelists. Thank you, Supervisor Simitian, for bringing this together. It was exceptionally informative and useful, and I think we can really drill down with a little bit more specificity and have clearer expectations as to how we can support all of you in getting as quickly as possible to that 4,000 capacity so that we can, again, check off another indicator and continue moving forward and safely reopening our county.
Thank you. Let me add my thanks to you, Dr. Kong. I know everyone's got a busy schedule these days, particularly those of you who are working day to day on these challenges. Thank you to Dr. Fensterscheid and the team. And while it may go without saying, I'll say it anyway, which is if either I or my colleagues are pushing you on these issues, it's because we share your determination to do the very best we can as quickly as we can and mitigate the downsides of a tremendously challenging set of circumstances. Dr. Kong, thank you. Dr. Fensterscheid et al., thank you. And let me turn now to the clerk and ask how many folks we have queued up to speak, not on item number 3, but on item number 2, this item, who would like to weigh in.
Thank you, Mr. Chair. Currently, we have 7 speakers in the queue.
Then here's what I'm going to suggest, Supervisor Ellenberg. I know you have a hard stop at 3:30. What I'd like to suggest is we let everyone speak for 2 minutes, given the importance of the topic. And then when we get to item number 3, public comment, I will hang in to take the public comment from folks who want to speak on other issues that are not related to today's topic. Does that work for you?
Thank you. I appreciate that.
Thank you. My schedule will accommodate it. Then let's ask the clerk to work our way through those 7 speakers, and we welcome them and thank them for their patience. I hope the panels have been informative for them as well.
Thank you, Mr. Chair. Our first speaker is Titia Ferralis. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, my name is Tisha Ferralis. I'm an RN at Regional Medical Center, Labor and Delivery. I've been working there for 23 years. I'm here to talk to you guys actually about the closing of our departments. We have some concerns. The planned closure of women's services will shut out the women of the east side of San Jose to direct expert care of labor and delivery, NICU, and postpartum care. This is a gross injustice towards an already marginalized and underserved population in our east side community. Time is brain in an emergency, and we have minutes to deliver a baby in order to avoid irreversible damages. Having women shipped across town to receive care can have dire consequences for mothers and babies. We are in contact with over 120 women per month, and we provide vital care that is needed in our community. The planned closure will create a healthcare desert for the women and babies of the East Side San Jose. The closure of women's services means that women who are seeking medical care in pregnancy will now be rushed to emergency departments where they can potentially be placed next to a COVID-19 patient, further endangering the community. We are calling on the Santa Clara Board of Supervisors to use your authority to stop the closure of women's services at Regional Medical Center. Thank you.
Thank you. And let me go to the clerk for the next speaker. I'm not sure if that last speaker was on item number 2 or item number 3, but we will say thank you for your comments and duly noted. Next speaker, please.
Thank you, Mr. Chair. Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
All right. Good afternoon, everyone. Scott Largent. I do appreciate hearing the updated information coming out of the Health and Hospitals Committee. My issues that I'm having right now, in a previous life, a lot of you know that I ran an electronics business, and I fully did understand the supply chain process. And what I'm worried about right now is, from the chit chat back and forth here, is whoever's in procurement, whoever's, putting their, I guess what I'm trying to get at is somebody needs to start putting their foot on someone's throat. They need to start getting this stuff done. And especially with somebody going out and buying a brand new piece of equipment, and the fact we couldn't have the manufacturer have that thing here in damn near a half an hour. We're spending millions of dollars on equipment. Start pushing these people to get this stuff done. It's not very difficult. And another issue that I really have is, how many committees do we have to make? How many other times do we just have to? It's a lot of talk. And pardon my language, you can't bullshit a bullshitter. And that's what I'm hearing a lot of on here. You supervisors have been told things were going to roll out, things were going to happen, testing was going to expand, blah, blah, blah. You've been told a ton of different things. This is just like the reentry network. We focused on booze for 3.5 years when it was a meth issue, and we had experts coming in there, people from the community, everybody spoke, nothing got done. And look at the disaster over that. We're going to have the same thing play out here right now. You are being lied to a lot. And Healy, what is he doing on on a testing committee, or what is going on here? This guy couldn't even house people properly right now when he stuck meth addicts with elderly women with no criminal records. He let that whole thing go down in fire. And you're going to have him involved in the testing end of things like that? I'm scared. So thank you.
Our next speaker is, I'm sorry, please go ahead, Mr. Chair.
I was just going to say, next speaker, please.
Our next speaker is Patrick McGarity. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hello, supervisors and county administration. This is Patrick McGarity, San Jose City Council member Sylvia Arenas' chief of staff. And thank you, Susan Ellenberg, or Supervisor Ellenberg, for asking for key information about the Latino community in East San Jose. Councilmember Arenas is deeply concerned about the new information coming out regarding high death rates in East Side zip codes, which only became public through the Mercury News. We're appreciative of the information provided today, showing that lab results demonstrate the same clusters, and that the East Side is continuing to see more test sites. However, the council member is concerned that none of the test sites allow walk-up testing, when we know that as many as 1 in 3 families on the East Side lack internet access. Many of those families are the exact ones at high risk for the virus due to their job exposure and overcrowded living conditions. Our community needs you to make the East Side test sites be open to walk-up requests. Oakland works with Verily too, and they have already rolled out testing in East Oakland, walk-up testing in East Oakland. Councilmember Arenas also asked the county to provide the public and the city with clear information regarding the state of the viral spread in San Jose's East Side. The city cannot protect our community with targeted efforts when the county does not provide this critical information. Thank you for your attention to this matter.
Thank you. Next speaker, please.
Supervisor, I just want to quickly interrupt. I know that we don't typically address public comments or items that aren't on the agenda, but I wonder if we can get a quick answer from Key or Dr. Fensterscheib or anyone else who's still on as to whether that's in fact still true, that we don't allow any walk-ups to the testing sites. That is a concern.
The OptumServe sites should allow walk-ups because that was part of the reason they decided to put it in. The state decided to put them in buildings is so that people can actually go to a physical place and not have to drive up.
So thank you. I appreciate that. Dr. Smith, can you get back to us with information as soon as possible as to whether the sites, particularly on the east side of San Jose, are all allowing walk-up visits? And if not, which ones are, so that we can publicize that information, please?
Okay, we'll get back to you with an off agenda.
Thank you. Pardon the interruption.
Not at all, and thank you to Councilmember Arenas for having her staff participate. Next speaker, please.
Our next speaker is Francis Herbert. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, my name is Frances Abair. I'm the Chief of Staff for Councilmember Carrasco. And over these past 2 weeks, our staff has actually gone to both the testing sites at Pal and James Lick. We've faced significant barriers in getting access to these sites. They are not walk-up. They still require internet registration, and the registration process is overly burdensome and requires a high level of technical ability on your phone. In addition, the phone number to register for the James Lick site has been overwhelmed. It's taken over an hour for our staff to get through to someone. We've also had issues with people who register with Spanish only speaking as individuals, and then they get text messages after they've taken the test that are only in English. We also request that people are able to come into the site, get tested without this pre-registration that's through the internet, and to increase outreach into our community. And I've provided some of the staff members with ideas that the council member has developed to broaden our reach at these 2 testing sites, especially as we know that the highest numbers are coming out of these zip codes in the county. Thank you.
Thank you. Next speaker, please.
Our next speaker is Sue Dreeman. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Sue Draymond from Palo Alto Weekly. I had just 2 quick questions. The goal of the 4,000 per day, is this inclusive of testing that's being done by private labs and hospitals, or are those outside of that number? And if that's the case, do you have a way that you're tracking those numbers, and kind of what's the total number of people who've been tested as an aggregate of all of the sources?
This is Supervisor Simitian. Let me say hi to Ms. Draymond, who I know from the Palo Alto Weekly. Ms. Draymond, we typically don't use public comment as an opportunity for press inquiries, but I think I can turn to Dr. Fensterscheib and Dr. Smith and say that when we're talking about a target of 4,000, that's from all sources, whether they be commercial, academic, or public agency, all inclusive. Gentlemen, am I correct in that recollection?
Yes, this is Dr. Cody. That's absolutely correct. So we're measuring any laboratory test done on any resident of Santa Clara County by any lab. And so you can see that on the website, on our testing dashboard.
Dr. Cody, and my recollection is that several weeks ago, you made a point of issuing an order that required all labs to not only report their positives, but their negatives as well, so that we had a complete sense of both how many folks had been tested and what the positive rate was among those that had been tested. Am I remembering that correctly as well?
That is correct. And I also just want to note that on that same dashboard, you can also see the average turnaround time across all labs serving county residents.
All right. Hopefully that facilitates the inquiry, and we'll go on to the next speaker.
Thank you, Mr. Chair. Our next speaker is Mark Joing. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Mark Joing, I'm a resident of Palo Alto. I first would like to commend the county supervisors and public health leaders in the county for the efforts in leading this county to quickly address the COVID-19 pandemic locally. I think overall, an outstanding job. However, I believe we are now missing the mark in regards to the PCR testing goal. The primary purpose of more testing, as I understand it, is to ensure that we identify most infected people so that we can isolate these people and test and isolate the contacts of these people. The WHO has recommended enough testing to achieve a positive test rate below 10%. Others have pointed to countries like South Korea and Taiwan, who have positive test rates close to 3% or even lower. And as can be seen in looking at this testing dashboard, which is excellent, by the way, we can now see that we're the only county actually in the top 5 most populated counties in the nation to successfully drive this positive testing rate to less than 2% in our county. And we've now achieved that over the last 2 weeks, and it's continuing a flat and downward trend. So I would like to understand why we continue this discussion around pushing to achieve a goal of 4,000 tests per day, which may have been a reasonable goal when we had 60 to 75 positive tests per day. And I would also like to understand why we're not moving forward with an effective plan to safely begin reopening the economy when it's clear we have the hospital bed capacity, testing capacity, and tracing capacity to start this process today in our county. Thank you.
Thank you for your comments. I believe we have one more speaker. Looking to the clerk to confirm.
That's correct, sir. We have one more speaker. Our final speaker on this item is Robert Aguirre. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Yes, Robert Aguirre here. I would like to point out, as Francis Hubert pointed out, that there is no walk-up that's available for people. And as you know, I'm an advocate for the unhoused, and the unhoused typically don't have a vehicle, and they get around either on a bicycle or public transportation, or they end up walking. And so we're not really testing the people that are unhoused at the same rate that we're making available testing for people that are housed. And we have a very large population of people here in the county, approximately 10,000 people. And last I heard, the number of people that were actually being tested was in the numbers of like 200, which is a very small percentage of the entire population. I think we need to provide more places where people can go that are much more available. And as I have pointed out before, if people that are going out to these encampments are armed with infrared thermometers, they can at least pre-screen some of the people and determine if there are any people out there that are particularly vulnerable or particularly susceptible to coronavirus. And if we have a way to actually bring people or have people go to testing so that we can start actually capturing these people before they spread this disease much further. And I know once it gets into the unhoused population, it's going to go like wildfire, because there's a lot of people that go from camp to camp, and we need to be able to isolate those people right away. And it's just not happening the way it should. So please reconsider that and provide a place for people to go to get walk-up testing. Thank you.
Thank you very much. Let me confirm with the clerk that is the last speaker on item number 2 on our agenda.
It is, sir.
Thank you very much. Let me ask the clerk then, moving on to item number 3, which is public comment on our agenda. And public comment, of course, is that portion of our agenda set aside for comment by members of the public who wish to address the committee on non-agendized items properly within the jurisdiction of our committee. How many speakers, if any, do we have for public comment?
We currently have 5 speakers, and more people are adding on as we go, sir.
Well, then I think what I'll do, with the consent of my colleague Supervisor Ellenberg, given the fact that we're running long, is ask each of the speakers to speak for just 1 minute today, rather than the typical 3 minutes, and at least highlight their issue or their concern. We will make sure that we get their comments into the record And the other thing I would say is let's give it just another 2 minutes, Mr. Clerk, and then I'm afraid we'll have to cut off the number of folks in the queue to try and wrap this up as close to 3:30 as we can. So,
Understood.
let's go with one.
Supervisor, as I indicated earlier, I do have to go, but I will certainly listen to all of the public comments later, since this is a recorded meeting. Thank you very much again for your time, and take care.
Thank you. Let me go to the clerk and ask if you would go ahead and queue up the folks who were going to speak under public comment.
Yes, sir. The first speaker is Janine Birkeland. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Hi, my name is Janine Birkeland, and I've been a nurse at Regional Medical Center in labor and delivery for 27 years. I'm a proud member of the California Nurses Association, and I'm here to talk to you about the concerns I have with the hospital's planned closure of Women and Children's Services on May 30th. Regional has not realized the impact of specialized nursing care on such a momentous occasion in a mother's life. Women deserve this unique care regardless of whether this care is profitable. A large majority of women in the surrounding neighborhoods are socioeconomically disadvantaged. They have less access to resources and prenatal care. These women need our department services more than the average woman. The hospital has no plan to monitor the fetus with a fetal monitor. The fetus is a patient also. This is the only way of determining the fetus is in trouble or not. They have no voice. We have to be that voice.
Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Thank you very much.
Okay, I believe I'm on. Sounds good. I'll get it taken care of in a minute. No, I'm on here right now. But so I've been kind of navigating some things recently. I mean, I know everybody's kind of been going through hell on the COVID-19 gig. Just one issue I had with a driver's license renewal. I had gone to the DMV and they give me the little printout, and just to be able to get that thing fixed and to get the other printout, it was just damn near impossible. So navigating these little things are very difficult. Same with getting visitation orders enforced through our courts right now. I find myself running around in circles. Now I know I'm off and on homeless right now, and I am, technically living on the streets, but it makes it hard for people that are supposed to be quarantining and staying away from situations. And I've got to be in there fighting for the basics. I don't get it. A lot of people are having to deal with it. So thank you.
Our next speaker is Julie Way. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Hi, my name is Julie Way. I'm a nurse at Regional Medical Center of San Jose, and I've been there for 29 years. Regional plans to close permanently its labor and delivery and NICU units May 30th. This will result in them not meeting the demands of EMTALA, the Emergency Medical Treatment and Labor Act, which requires a medical screening exam, for they will not be providing fetal monitoring to see if pregnant women and her fetus are stable for transfer. I believe if they proceed, Regional should lose the privilege of being a trauma center, especially to any female of childbearing age. When HCA acquired Regional, the old Alexian brothers, they promised to meet the needs of the community, which they will not be doing if they close labor and delivery in NICU. I request the Health and Hospital Committee to do whatever it can to prevent this. Thank you.
And our next speaker, please. Thank you.
It appears that this is our final speaker, Mr. Chair. We've had some people drop off. So our final speaker on this item is Melody Masanai. I apologize for the pronunciation. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Thank you. This is Melody Masani, and I am grateful for this time to address you. And thank you, Mr. Chair and Vice Chair Ellenberg, for this opportunity. I am speaking on behalf of Samoans everywhere and the Polynesian task force that we are forming of Native Hawaiian and Pacific Islanders in the San Francisco Bay Area. I am very hopeful in that Dr. Cody had published the Asian and Pacific Islander Health Assessment in 2017, as was requested by Supervisor Simidian. What we will be asking in the form of a letter, which will have some attachments, with statistics that are concerning to us, is we will simply ask to have the Native Hawaiian and Pacific Islander data disaggregated from the API data as reported. Thank you.
Thank you. And if the last speaker can still hear me, I wanted her to know that I did hear her closing comments, even as her time came to a wrap. Thank you very much. Let me ask our clerk then. I believe that completes all of the agendized items on today's meeting agenda. Can you confirm that for us?
That is confirmed, sir. Yes.
All right. Then without objection and hearing none, we stand adjourned, and thank you again to all who made it a very helpful hearing for our county. Much appreciated.